Welcome back to the Deep Dive. Our mission is always the same. We take complex research, dig into the source material you've shared with us, and, well, we try to deliver the most essential insights.
Today we're tackling a really critical area in oncology. It's about optimizing treatment for head and neck cancer, or HNC.
Right.
And despite all these, incredible therapeutic advances in surgery, radiation, chemo, we've still got this hurdle.
The survival outcome.
The survival outcomes.
True.
For locally advanced HNC, they're often suboptimal. So we know we need better predictors, something more than just, tumor size and location.
That really is the challenge, isn't it? The traditional playbook, it relies so heavily on classifying the tumor itself.
Yeah.
Where is it? What stage?
Exactly.
But the evidence you've pulled together for us, it suggests we've been looking too closely at the local problem and maybe missing the bigger picture.
I think that's a perfect way to put it. We're now seeing, just overwhelming evidence that it's the host-related factors that are often decisive.
Host-related, so you mean the patient themselves?
Yes, exactly. How metabolically healthy is the patient? What's their nutritional status? Their overall physiological reserve? These things dictate how well someone tolerates aggressive treatment and, critically, how long they survive.
Okay, so let's unpack that. It's like we're viewing the patient's body as an engine. You can have the best treatment strategy, the perfect racetrack, but if the engine is failing...
the car is not going to finish the race. That's a perfect analogy.
So our deep dive today is centered on a way to actually measure that engine quality.
It is. We are analyzing the development and the initial evaluation of something called FUNC-RISK. It's an AI-assisted risk score.
AI-assisted.
And it uses body composition metrics that are pulled entirely from routine CT scans to predict overall survival in these HNC patients.
So FUNC-RISK. That name implies it's looking at function, not just the physical disease, and the whole foundation here is muscle health.
Absolutely. The core idea, biologically speaking, is that sarcopenia,
which is the loss of skeletal muscle mass?
Exactly. That and the related issue of impaired muscle quality. This often shows up as fat infiltrating the muscle tissue.
Okay.
And these two things together, they're powerful prognostic markers. We see them linked time and again to higher toxicity, treatment breaks, and, ultimately, poorer survival. They're a proxy for what's really going on systemically.
And just for context for you listening, this deep dive is grounded in a specific source. It's a single-center pilot study, right?
That's right. It involved 65 HNC patients, so it's a feasibility study. It's asking, is this AI-based approach reliable? Is it effective at predicting outcomes?
So it's the first step.
It's the first step. It's turning what was once sort of a clinical guess into an objective, data-driven assessment.
Okay, so let's get into it. Yeah. How do we go from this idea of physiological reserve to an actual hard number? Why does muscle matter so much, and how do we even measure it?
Well, the gold standard for measuring body composition is still computed tomography, the CT scan. It's the reference method.
Right.
By looking at specific cross-sections of the body, we can quantify the total area of muscle. And just as importantly, we can measure the density of that tissue using something called Hounsfield units, or HU.
Lower density meaning lower quality.
Generally, yes.
Now, this is where it gets really practical. When I hear about these kinds of studies, they usually reference a slice taken way down in the abdomen at the L3 vertebra. Why are we talking about the neck?
And that right there is the crucial aha moment. It's what makes this research so applicable.
Okay.
L3 is the traditional gold standard, you're right, but HNC patients, they almost never get abdominal CT scans as part of their routine care.
Of course. Their radiation planning is all focused on the head and neck, so you already have those scans.
You already have them. And researchers have rigorously validated measurements taken at the third cervical vertebra, the C3 level.
So right up in the neck.
Right up in the neck. And these C3 metrics, they show a really strong correlation with the traditional L3 metrics. And critically, they retain that prognostic power in HNC populations.
So if you're a clinician, this is a game changer.
Yeah.
You don't need a new scan, no extra appointments, no more radiation exposure for the patient.
Exactly. The data you need is already sitting there, right in the RT planning scan you were going to do anyway.
Its power is that it leverages existing data.
Yes. But while the data is there, getting the measurements out of that data has always been the big hurdle.
You're talking about manual segmentation. Someone physically tracing the muscles on the screen.
I am. It's so labor-intensive. Many of the prior studies relied on these manual or semi-automated methods. A person has to sit and painstakingly trace the muscle outline, slice by slice.
Which takes how long?
10, maybe 15 minutes per patient. It's just not feasible in a busy clinic. And even worse, it introduces observer variability.
Meaning, if you and I both trace the same muscle, we're going to get slightly different results.
Inevitably, especially where the boundaries are a bit fuzzy. So the measurement itself becomes subjective. And if your goal is standardization, that variability is a non-starter.
And that methodological barrier is what the AI solution is designed to solve.
Precisely. Which brings us to the core innovation here.
The AI-assisted solution. So how does deep learning actually fix this problem of time and variability?
It's been a real game changer. These deep learning algorithms, they can be trained to recognize and automatically segment specific muscle groups.
In this case, the cervical muscles at C3.
Yes. And it does it with speed, with reproducibility, and with complete objectivity.
So the human element, the variable tracing, is just gone. You're left with a standardized process that you could apply to huge amounts of data almost instantly.
Exactly. This is what allows us to rapidly extract what we call morphometric biomarkers from large patient groups. It's what makes this kind of personalized risk profiling actually feasible in the real world.
Okay, let's look at the actual data points the AI pulled out for the FUNC-RISK model. What are the three key metrics?
So the AI focused on three complementary parameters at that C3 level. First, you have SMI, the cervical skeletal muscle index.
Okay, SMI.
You can think of this as muscle quantity. It's the total area of skeletal muscle, but it's normalized for the patient's height.
So it's the sheer amount of muscle they have, their reserve tissue.
Correct. Second, we have IMAT. That's the intramuscular adipose tissue area.
So fat inside the muscle.
Yes. Fat infiltration within the muscle bundles. It's often called myosteatosis. And a high level of this is a clear sign of metabolic dysfunction.
So SMI is the size, IMAT is what it's made of. What's the third element?
The third is HU, the mean muscle attenuation. This is our ultimate measure of muscle quality or density. Healthy muscle is dense, so it has higher HU values.
And I assume before they even built the final score, they had to check if these metrics actually predicted anything on their own.
They did, and this is where one of the most compelling findings of the whole study came from.
Oh.
In the univariable analysis,
Yes.
Looking at each predictor one by one, the standard clinical factors.
Like age, tumor stage.
Age, sex, tumor stage, even the type of treatment they got. None of them were statistically significant predictors of overall survival in this particular group.
Like, that's genuinely shocking. The things that doctors rely on every single day, like staging, they were statistically neutral here.
They were, but the body composition metrics were not. Both SMI, the muscle quantity, and IMAT, the fat infiltration, were significantly associated with overall survival.
So the patient's engine health was a better predictor of survival than the tumor size.
It was a more powerful, independent prognostic factor in this cohort, and that provides the whole foundation for unpacking FUNC-RISK itself.
The survival equation.
The survival equation. FUNC-RISK is what we call a continuous composite risk score. It takes all three of those AI-derived metrics, SMI, IMAT, and HU, and combines them.
Using weights from a statistical model to get the most predictive power.
Right, and the result is a single number that tells you the patient's mortality risk.
Okay, so let's get to the core of it. What is the actual formula?
The equation is FUNC-RISK, SMI plus FUI.087 plus 0.011 SHU.
Okay, let's break that down. The key is interpreting the plus and minus signs on those coefficients. A higher final FUNC-RISK score means a worse outcome.
A poorer outcome, yes.
And SMI and IMAT both have negative coefficients. So that means higher SMI, more muscle is protective. That makes sense?
More muscle, lower risk.
But wait, why does higher IMAT, which is the intramuscular fat, also have a negative or protective coefficient? I thought that was a bad thing.
This is a really critical nuance, and it kind of goes against what we'd normally think. Generally, yes, we assume high IMAT is bad,
Right.
but in this specific multivariable model, the protective effect of the muscle quantity, the SMI, is so dominant.
So SMI is the big factor here, pulling the overall risk score down.
It's the big one. And it's also possible that for a patient dealing with this aggressive catabolism you see in HNC, a patient with a little more fat stores, even if they're inside the muscle, still has a greater physiological reserve than someone who is completely wasted.
Ah, so you're saying a bit of fat infiltration might just be a side effect of having enough tissue in general versus the primary driver of risk, which is having no muscle at all.
That's the interpretation the researchers favor. It really highlights the complexity here and the specific context of, HNC-related cachexia.
I see. Okay. And that leaves HU, the quality metric, with a small positive coefficient.
Correct. Since a higher FUNC-RISK score is bad, The positive coefficient on HU suggests that in this combined model, higher HU density is actually correlated with a slightly higher mortality risk.
Which again seems counterintuitive.
It does, but remember, all these variables are correlated with each other. The main takeaway for you, for the listener, is simple. The final composite score is the powerful predictor. Higher score, greater risk.
All right, let's get to the moment of truth. They calculated this score for all 65 patients and then split them into a high-risk and a low-risk group. How big was the difference in survival?
The difference was massive. It was profoundly clinically meaningful. When you look at 5-year overall survival, the low-risk group, the ones identified by FUNC-RISK, they had a 5-year OS of 71.9%.
That's a strong outcome for HNC. Over 70% at 5 years.
It is. Now, compare that to the high-risk group, who were identified purely by this AI score. Their 5-year OS plummeted to just 39.4%.
Wow. That's a difference of more than 30 percentage points in survival.
Just based on these muscle metrics alone, think about what that means. You can identify the patients who will likely do very well, and you can spot the ones who are facing a huge physiological battle from day one.
It's over a year of life difference in their mean survival times. 54 months for the low-risk group versus just 41 for the high-risk.
And the median overall survival wasn't even reached in that low-risk group during the study. They were that robust. But the median for the high-risk group was just 41 months. The model's performance is pretty solid, with an AUC of about 0.73 at 3 years, and it holds up over time.
This brings us to the clinical implications. What does this mean for a clinician sitting with a new patient? What's this so what here?
The value is entirely proactive. FUNC-RISK gives you an immediate objective biomarker that flags high-risk patients before you've even finalized the treatment plan.
And you get this information from scans you already have.
From scans you already have, which means you can start timely, aggressive interventions right away.
So instead of waiting for the patient to start losing a lot of weight or getting fatigued and then trying to play catch-up.
You intervene early. A high FUNC-RISK score could trigger mandatory prehabilitation, specialized nutritional counseling, maybe physical conditioning programs to build up that physiological reserve.
It's about getting the engine ready for the race.
That's exactly it.
So to recap the strengths, it's fully automated and objective because of the AI.
Correct. No more manual tracing issues.
It uses the C3 metric, so it's universally applicable in HNC clinics.
Mm-hmm.
And it was developed without clinical factors, which really isolates and proves the independent value of muscle health.
It does. It makes a very compelling case.
And there's always a with a pilot study. We have to be cautious here.
Absolutely. We cannot overstate the findings of a study with just 65 patients. The sample size is modest. It limits how much we can generalize from this.
And any hazard ratios or specific numbers need to be taken with a grain of salt.
They do. They need to be interpreted very cautiously. The next logical step here is mandatory external validation.
Right. It needs to be tested in a much larger, more diverse group of patients.
Exactly. The researchers are very clear about this. External multi-center validation is absolutely required before something like FUNC-RISK is ready for the clinic.
So for now, it's a complement to traditional factors, not a replacement.
It's a complement. It provides this incredible piece of biological insight into resilience that, traditional staging just can't give you.
So to summarize our deep dive, FUNC-RISK gives us this preliminary but really powerful evidence that combining these AI-derived muscle metrics can stratify patient risk in a way that's maybe far more meaningful than what we've been using.
It's a foundational step. By quantifying something that was previously either subjective or just too cumbersome to measure, this tool helps shift the clinical focus. It moves from just aggressive tumor treatment to optimizing the patient's entire physiological environment.
As we look forward, what's the big implication here? If FUNC-RISK is telling us that these host factors, muscle metabolism, are dominant predictors of survival, what does that mean for our priorities in patient care?
Well, that raises a really challenging question for oncology. If this model holds up in larger cohorts, should those first few weeks after a diagnosis focus less on, say, planning the complex radiation margins and more on aggressive, proactive metabolic and physical prehabilitation?
Get the patient ready first.
The future has to look at integrating this with other biomarkers like systemic inflammation. But the ultimate challenge is, do we start prioritizing saving the engine before we even start the race?
An automated health profile that forces us to prioritize personalized preparation over immediate targeting of the tumor. That is a fascinating potential shift. Thank you for guiding us through this.
My pleasure.
And thank you for joining us for the deep dive. We'll see you next time.